So I'm going to talk to you for the next half hour or so on how to deliver optimal end-of-life care support, particularly talking about older adults in Ireland. And I'm just going to break the talk up into maybe three different parts. We might give you a little bit of context about the elderly in Ireland and about their care needs. And then we'll talk about care needs at the end of life and how to provide that, and also how to support families in that as well around the death of a loved one. So people in Ireland are growing, getting older and living longer. As you can see from the graph, it's been steadily increasing over since 2003. So that's nearly 20 years of data. But sorry, that's from 2003 to 2011. You can see that the average age for people, for females is 83, and for males, it's about 78.5 years. Having said that, people who live beyond the ripe old age of 70 years of age can expect to have 5 comorbidities to contend with. So what does dying look like in Ireland? What are the trajectories or the patterns or the pathways that people take to dying in Ireland? Well, if you look at the top left-hand corner of this graph, on the slide, you'll see that you have sudden deaths where people maybe die from a cardiovascular event or a road traffic accident. That's a sudden death. Then we move over to the top right-hand side, and that's people who get perhaps a terminal illness, a cancer, where there's a very definite terminal phase to their illness. On the bottom left-hand side, we have people who are dying from organ failure. Perhaps we're talking about cardiac disease or heart failure, or we're talking about COPD. That these are people who will have highs and lows in their decline over years. And then we have people who pass away or die from frailty, from old age, and indeed increasingly here in Ireland and over in the NHS for many years now, we have frailty teams, and frailty is a legitimate diagnosis on a death certificate. So adults towards the end of their life here in Ireland, how do they engage with the healthcare service? Well, in the last year of their life, elderly people in this country can expect to visit their GP 6 times and have 1 hospital admission. And these figures are from the TILDA study, which is ongoing, but this is the most recent tranche of information that they've released from it in 2017. 12% of elderly adults in this country will die in a hospice. 18% will die in nursing homes. 45% will have the involvement of public health nurses, and 20% of elderly adults will avail of home care services. Where do the elderly in this country die? 46% of them will die in a hospital, and that's quite a high percentage. There's been research done which shows that in the main, in 7 high-income countries in Europe, the average is between 22 and 52% of people dying in acute hospitals. So you can see we're right up at the high end at 46% of our elderly dying in hospitals. And that tells us a lot about our healthcare system. It tells us that our healthcare system is not fit to care for people, elderly people especially, who want to die at home in the community. 20%, 27%, however, will die in their own homes. 12%, as we said, will die in hospices, and 10% of people, elderly people in this country, will die in a nursing home. What's the cause of death in older adults in Ireland? 38% of it is from cancers, and 31% is from cardiovascular disease. And other diseases are respiratory diseases and gastrointestinal diseases, which also make up a proportion of deaths. How long are elderly people in this country generally unwell for, or have an illness, a duration of illness or disability? Well, as you can see from the figures there, 29% are less, are ill for less than a month. And of that 29%, half of them, 50% of them, died quite suddenly. 21% will be ill for between 1 to 6 months, and 70% for between 6 to 12 months, and 33% would have been ill for a year or more. So what are the challenges in looking after the elderly towards the end of their life? Well, I took this quote, it's from 1997. It's years old, but I still think it's very, very relevant. Older people are often treated as if they have already stopped living, and people treat them differently. However, a significant number of older people have health problems towards the end of their life that can be modified, and their quality of life can be improved. And we're talking about things such as pain, depression, and falls is another category as well. So elderly people have conditions that where if the correct intervention, the correct care is provided, their quality of life will be improved. And that begs the question, what is palliative care and where do we sit in this? Well, palliative care is an approach that improves the quality of life of patients and their families who are facing the problems associated with life-threatening illness. That's the World Health Organization definition from 1970. There's a new definition doing the rounds at the moment. It hasn't been endorsed fully by the World Health Organization, but it has been drafted by the International Association of Hospice and Palliative Care. But their definition says that palliative care is the active, holistic care of individuals across all ages with serious health-related suffering because of severe illness, and especially those near the end of life. It aims to improve the quality of life of patients, their families, and their caregivers. As I said, not fully endorsed by the World Health Organization, but I think the key phrase in that definition is to talk about all health-related suffering, rather than just physical pain and psychosocial issues, all health-related suffering. So what we do in palliative care, we help to relieve pain and other distressing symptoms. We affirm life. We regard death as a normal process, and it's not within our remit to either hasten nor postpone death. And we also integrate not just the physical care, but the psychosocial, psychological, and spiritual care of people as well. And we very much believe, and I saw a lady in our oncology day ward this morning, and I spoke to her. It was our first interaction with palliative care, and I very much stressed that I was helping her to live as well as possible for as long as possible. And that's the definition I like to use when I meet patients for the first time in outpatients. It's the definition that I use, that's to help people to live as well as possible for as long as possible. And the important word there is live. We also help families through illness and into bereavement as well. And that's part of our role here in St. James's. So what does a good death look like? Well, Meyer and her colleagues in America in 2016 released a paper called Defining a Good Death, Successful Dying. And if this has been an ongoing study, a longitudinal study for some time, and they identified 11 areas of concern for people who were dying. And this research was done on people who were in the last months of their life. And they broke it down into several areas, and we talk about the process of dying. So people were asked about the actual act of dying, and as you might not be surprised, a lot of people wanted to die in their sleep. That was the number one thing. Also wanted to die pain-free and not suffering. They wanted their emotional well-being to be recognized and for that to be looked after. A chance to discuss the meaning of death with their family and with other healthcare professions as well. They also wish that their own family members were prepared for the death, so that they received support. And the people didn't want to be a burden on their family, and that could be a fiscal burden or a time burden, but that was important to them, not to be a burden on their family as much as possible. Naturally, they wanted dignity towards the end of their life. And Bruce, I think, touched on this in his talk about life completion. Getting to say goodbye to people that were important to them, and that there's recognition given to them for a life that has been well lived, for the important things that they've done in their life. They'd like their religion and their spirituality to be recognized. They'd also like their treatment preferences to be noted and taken into account when treatment plans are being drafted. In relation to their quality of life, they talked about maintaining hope, maintaining pleasure, and maintaining gratitude in the last phase of their life. And they also spoke about the importance of maintaining or having good relationship with their healthcare professionals, both medical and nursing. And there's a category at the end called other, and in that they talked about these people who were canvassed, spoke about the importance of physical touch. And There has been research done to show that a lot of the times elderly people in the hospital, when they are touched, it's for clinical purposes only, for nothing more, not to go over and to touch for comfort, but just for clinical purposes. Also the recognition of one's culture, and also to have available your pets, if you wanted to. And I saw something online quite recently. There's a hospice in North Spain, where they actually have a stable, and they keep a number of horses in the hospice, and the horses are allowed into rooms to visit people. So that can be important. Pets and animals and touch can be important for people. So a person only dies once, and if we don't recognize that somebody is dying, and we don't recognize it in a timely manner, we can miss it, and we can miss very important opportunities to make that time as best as possible for them and for their family as well. And good care towards the end of life has a knock-on effect, a good knock-on effect for families going into bereavement. So if it was a good death, the bereavement tends to be a little bit better as well. And we only have one chance to get it right, one chance to get someone's death right. And my advice is be as human as possible. Bruce spoke about my friend from the States who has the book, the American Book of Death and Dying, and he talks about showing up. Show up. You don't have to have any fancy words. People who are dying and their families, they're on a slightly different trajectory than us. We'll leave here, we leave this conference this afternoon, and we go do stuff, and we're busy. Many people who are dying, their priorities are they're not the same as ours. We're on the up, they're on the horizontal. So just show up, no fancy words. You don't have to have any fancy words, but just be as human as you can. And I'm reminded of a saying that goes that it's great to be able to say hello in 4 or 5 languages, but it's even better to be able to sit down and say nothing in any language whatsoever. And I've found throughout my career, using silence and just showing up, that's some of the best things that you can do. Normal questions, human questions. How long have you been married? How many children have you had? What do you work at? What did you work at? And of course, many elderly people will have worked in professions or trades that are no longer fashionable, such as seamstresses and tailors and that. So you can ask them all sorts of questions about those things. If there's a photograph in the room, you can also ask them about the photograph, who's in the photograph, and what does that person mean to them. So being human as much as possible. But just to say that death is not always neat and tidy. It is not always neat and tidy. I'd love to say that it was, but it's not. And sometimes the best possible outcome is not the ideal outcome, or the outcome that family were wishing for. And, relief is not always available for every aspect of human suffering. And I always, when I meet patients for the first time and they've said, I'm meeting you for pain control, I stop them and say, I wouldn't use the word control. I'd be very arrogant of me to sit here and say I can control your pain. I can certainly manage your pain, and between us we can manage it a lot better, but I can't control. I can't have full control over your pain. Just to remind oneself as well that death does not always equal failure. Death does not equal failure. There's a physician down in Cork. His name is Seamus O'Mahony. I still think he's practicing. And back in 2016, he wrote a book called The Way We Die Now. And he was quite critical of palliative care and quite critical of how we treat dying people in our acute general hospitals in this country. And he talks about dying being banal and anticlimactic, robbed of its significance in our hospitals. It's made grand and mysterious, and people are hidden away in side rooms, which is, to a large extent is true. And he argues that the doing of it should not be reduced to a set of tried and tested maneuvers. SOPs, care plans that we stick by and tick off and say and sign. It's an interesting book. It's called The Way We Die Now, Seamus O'Mahony, 2016. I think death has been portrayed as being, by the modern hospice movement, has been portrayed as being very dignified because we have been largely successful in managing physical pain towards the end of life. But the elderly have many other pathologies other than pain: urinary incontinence, fetal incontinence, coughing on fluids, frailty, weakness. These are quite challenging to manage in an elderly body that has no reserve. And the process of dying in older people tends to be less clear-cut than it is in younger people. The dying trajectory can be longer, and perhaps sometimes there's less awareness because of cognitive impairment as to what is happening. And there's a quote from Newland's paper in 1994. I know it's an extremely old quote, but I still think it's very relevant. One of the participants in Newland's study spoke about death kept taking little bits of her. So I'm going to move on now, perhaps, and just talk about in the actual last hours or days or hours of life, and signs that death is near, and how to look after that person. So one of the first signs that you may see is a withdrawal, a drowsiness, increased sleeping, and or unresponsiveness. And this happens as the metabolism of the person slows down. There's decreased blood flow and oxygen to the brain. So what you can do is try and maybe plan activities for when the person is more alert. And sometimes people will have a pattern that they're more alert in the evening or more alert in the mornings. So if there are activities that's important to the person, try and plan them for around those times. If somebody is unresponsive or drowsy and sleeping a lot, the current thinking is that while they may not be able to speak, they can probably hear what's been said in the room. So include them in the conversations, never exclude them from the conversations. And I have a little line which I always use when I go into a room if someone's unresponsive, and I'd say, "Mary, we're talking about you. And there's only one thing worse than being spoken about, Mary, and that's not being spoken about." So I'd use little things like that just to help help a family and to help the patient as well. And also to reassure the person that their life was meaningful. And perhaps if somebody is withdrawing slowly and they're drowsy, just to reassure them as well that their family will be cared for in their absence. A lot of the time you will know the people that you're looking after, which is the best scenario. You will have looked after them for perhaps hopefully weeks, maybe months, and even perhaps years. So you'll have an idea of what's important and what the important things are to say to them. Some people may become a little confused, may become a little restless or agitated. So always try and exclude the reversible conditions. Is there an organic cause to this? We have a little saying in palliative care: reverse what is reversible. Treat the stress, the fear, and the physical and emotional and spiritual distress that comes with having a condition that may be causing you to become confused, be it if somebody is pyrexial, or if their biochemistry is way off the charts. And if you're in a position to be able to correct that, well, you certainly should be able to correct the temperature, but if you're in a position to correct that, please try and reverse those causes. Involve the family as much as possible and other members of the multidisciplinary team in discussions about how to best manage the patient. Gentle reminders if the person is confused, a little muddled, just gentle reminders as to where they are, what day it is, and what's happening to them. And it's important that there's clear and consistent messaging from all members of the multidisciplinary team with the patient and with the family. Very clear and succinct messaging as to what we are doing and what our expectations are. If people don't, if a person doesn't settle with reassurance, you might need to use some medications to help maintain or make them less anxious. The drugs that we use are here in the hospital. We use midazolam, which is a benzodiazepine, and it's quick acting and short acting as well. And we use it in small amounts, 2.5 to 5 milligrams, 1 to 2 early subcut. It can also be given buccally as well, which is great for if someone is at home and dying in the community, that it can be given buccally. It can be got from the chemist. If you need to use it in a syringe driver, we usually start off with about 5 milligrams over 24 hours and titrate that upwards as needed. Haloperidol is another drug which we can use to try and ease confusion. 0.5 milligrams to 2 milligrams subcut every 2 hours. And again, the range in a syringe driver is variable. We would use 1 up to 5 milligrams. If the person is not settling on midazolam or haloperidol, our second line would be levomethpromazine, 2.5 milligrams subcut every 4 hours. And again, in a driver, you start off at 6.25, but I've seen doses of 50, 75 milligrams of nosin in a syringe driver to try and sedate people who are agitated towards the end of their lives. The dose of midazolam can be titrated up very, very swiftly, and our cutoff dose for midazolam is 200 milligrams of midazolam subcut over 24 hours, and nosin 150 to 200 milligrams subcut over 24 hours. And if even at those doses, if confusion, restlessness, and agitation, I'm not going to so much confusion, but if restlessness and agitation remains an issue, then we would use phenobarbital to try and manage the condition. Reduced appetite and thirst. This happens because the body attempts to conserve energy, and processes like digestion will slow down and they'll eventually stop. And this one can be very difficult for families and carers to accept. You leave this conference this evening, you'll go home, and the majority of us will sit down and have dinner with our family, and it's a life-giving thing, it's a social thing. So when people can't partake in that, that can be very distressing for families, and it can cause a lot of angst amongst families. And it's something that I see in my practice, is that the husband or a wife comes in with the husband and she's really got a bee in her bonnet because her husband's not eating, and he just doesn't have an appetite. He just does not have an appetite for one reason or another, be it the treatments that we're giving him for his cancer or from the cancer itself, and is trying to negotiate between the two, but it can be very, very difficult for families to accept that someone's not eating. I always encourage, eat when you want to and eat what you want to, small and frequent, and what you like. And sips of water and sips of juice if you're not able to tolerate a full diet, or to drink copious amounts of glasses of water, so sips of water, sips of juice. And oral care is very important, not to forget about oral care for someone who's in the last phase or days of their life. Loss of bladder or bowel control. Disposable pads obviously remove same as soon as they become soiled. The urine will become darkened and concentrated, and probably become less as well. A catheter may be appropriate in preventing urinary retention, urinary obstruction or skin breakdown. And it wouldn't be unheard of to go along and review somebody and for them to be quite restless and to put your hand on their lower tummy and to find that the bladder is quite distended. So we would often suggest that a person has a urinary catheter inserted. Increasing pain can...
Sorry to interrupt you, Rory. Just to let you know, we've got about 5 minutes left before we do some questions.
Okay, all right then. Increasing pain, if the person is on a regular dose of opioid, it may need to go into a syringe driver. I've put a slide on about a syringe driver at the bottom of the presentation if people are interested about that. Make sure that the appropriate breakthrough medications are written up, so you have those to give for the patient as well. If the person's dyspneic, a regular breathing pattern, or they're making sounds, address that with them, and there may be a lot of fear and anxiety amongst the family around this. Often families feel that somebody is drowning because they hear what's commonly called the death rattle. They're not drowning. It's noisy breathing, and it happens because of relaxations in the muscles in the throat. And these again are the drugs that we can use. Now, that is not the correct drugs there. I beg your pardon, they're on the next page. There you go. There's the drugs we would use for dyspnea and irregular breathing. Like glycopyrrolate, which is Robinol, and hyoscine butyl bromide are the two most common ones that we use. So just to finish up, a little bit about care of the family. It's a very precious and a very stressful time, and it can reawaken pain from previous losses for people. People may feel guilty. Children may feel guilty when they're around their parents' bedside for one reason or another. Perhaps it felt that they didn't get to spend time with them when they were well. So there's a need for open and honest communication. And coping in bereavement is linked with a good experience around death. Children can be tricky. I could do a whole hour's talk on children around death and dying. People will know their own children best. There are resources on YouTube and written resources as well to give to children to help them to help explain what's happening to their loved one. Questions that you may be asked: is it okay if I go home in the next few hours? I always come back and say, well, look, would you be very disappointed if you were here and your mother had passed away when you're not here? And if they said yes, I'd say, well, then I think you should stay. Often get questions about should we bring relatives home from abroad? Again, I think it's if the person abroad would like to be here for when they died, and that they should come now. Also, it can be a stressful time for people who are around the bedside because they have to make plans for work, family demands, etc. Just to finish up, at the time of death, when somebody dies, just remember that it's a private time and it's a family time. Be there to reassure, but don't be the chief mourner. And don't rush to confirm the death. There's no rush to confirm the death. And no matter how long the person has been sick for, when they die, it's sudden. And respect the family, or the patient's and the family's wishes around prayer or ritual. And just to be slow, calm and serene, and to appear in control. There you go. Thank you.
Rory, thank you so much. And I'd say you could have kept talking for the day.
I could have kept talking for a week.
You're a wealth of knowledge. Now, I'm very conscious of the time, and people have been very attentive, and we've been very cheeky with having very few breaks today. But I might throw two questions at you if you don't mind. Okay, where now? I'm after writing on my other bit of paper. This is the problem. Right, hang on a second. I'm jotting them down as they're coming in. So, what would you say to a family that doesn't really want any intervention around end-of-life care? We'd see that sometimes where you think you've prepared the family, you've explained to them what's happening, and the next thing there's talk of a syringe driver and morphine. And people just go into, oh, he can't have that, or kind of asking, how is he going to manage when he's not drinking now? He should be put up in a drip, even though you've gone through the whole process and you feel that they're prepared. They kind of throw these things left of field. And how would you advise to address that? Yeah.
In relation to the fluids, and daddy's not drinking, I'd ask, but is daddy thirsty? Has daddy asked you for fluid, or is he thirsty? And a lot of my work is with cancers. 70% of our palliative care work in this country is with malignancies, and if that's the case, if the person does have malignancy, I would talk also that that the advanced cancers play tricks on the body, and they upset the normal hormone balance that's in the body, and the person may not be thirsty. The normal hormones and processes in the body that make us thirsty may not be happening for daddy at the moment, and if he's not expressing a wish to drink, well, then we shouldn't force fluids on him. And in fact, if we do give him fluids, he's so weak that he may cough, and he may swallow some of those fluids, and he may get a pneumonia, and perhaps that might not be the best thing for him. We can do some oral care, and we can keep his mouth fresh and his lips as fresh as possible. The first question in relation to morphine drivers, yeah, we do get that frequently, especially in the older population who are a little bit opioid phobic at times. And it's to reassure that we're giving incredibly small doses, which we are, we do start off with very small doses of opioids. I recognize the family's fear around it, I recognize the patient's fear around it, but we are going to start off with very small doses. It's going to be medically supervised. And I often break it out for them and say, well, if we're given 5 milligrams of morphine over 24 hours, that's less than half a milligram of morphine an hour. It's very, very low dose. And here are the benefits. Here's what we hope to get from giving this low dose of morphine. Respirations may become a little bit more managed, a little bit more controlled, and the pain will become less. And this may be a bit more dignified and better time for the patient and for the family as well.
Perfect. And the last question that we have is, I suppose, in the last year, the pandemic has thrown up huge challenges around how we deliver end-of-life care. And for us working in long-term care, we're used to supporting the family at the bedside, where now we've had instances of family members saying goodbye through windows, over the phone. And I suppose Bruce touched on that. There's a lot of, I suppose, unresolved grieving that people deal with afterwards. And how would you suggest that we, because look, whether it's COVID or something else, I suppose it's opened our eyes to that there's times when people just can't be there. So how do we maybe better support those family members who aren't maybe physically there for one reason or another, in that whole process, in preparing, especially if it's an expected death, and I suppose getting that sense of closure for people.
Yeah, it's been horrible, you know, in a word. It's been absolutely horrible to see people, some people dying alone, and other people perhaps dying with people that they didn't know, have no connection with it at all. And it's horrible, and it doesn't sit well. It doesn't sit well with all healthcare professions. It's just not what we do, and we know that it's not the standard of care that we would like and hope to give. But we have to do something. We can't be stunned by the pandemic. We have to be as proactive and do what we can. And at the moment, we are doing the best that we can. It's not what we'd like. It's not ideal care, but we are doing something. And for families and for patients, I really think what we can do is really well is our communication. Communication, make them feel as involved as possible, keep them as informed as possible, make sure that they know who you are, know your name, know that you're going to be looking after their mum for the next 5 hours or the next 8 hours on duty, and that they can call you and you will call them, perhaps make an appointment to go and call them. I think having them involved as much as possible is one way. But I think we have to put our hands up and we have to say, look, this is not ideal, and this is not the way we'd like to do it.
I suppose just on that point, one of the things that we did in our workplace, where family members couldn't be present, was we set up a conference call in the person's room. So even though at that stage they were minimally conscious, we spoke to the family about how hearing is the last sense to go. And it was actually quite lovely because it was over a period of days. So family members were singing favorite songs, they were telling stories, and it really helped with their sense of closure. They were there for the person.
Yeah, we've used technology as much as we can. The place is flooded with iPads and with smartphones, and we have people who will go around to the wards and assist the elderly who might not be au fait with technology, assist them to make calls to their family. If somebody is dying in the actual act of dying and they're not responsive or they're drowsy, having their favorite music on in the background and get that from the family, try and get from the family what would be important to the person, and maybe to have something, a token of theirs in the room, something that they would recognize from home as well. So yeah, it's very challenging, and as you well know, COVID deaths happened very quickly, and there's a huge turnover and I'm talking about here in St. James's. There's a huge turnover on the COVID wards. I think we've 2 COVID wards at present, but there's a huge turnover because patients deteriorate very quickly and then die quickly. Having said that, we are seeing, that was in the first and second wave. We are seeing now in the third wave, a lot of people, as you see, the numbers are down for ICU. So a lot of people are not going to ICU. A lot of people are getting better, or they're not dying, but they're still very sick, very, very sick, and need a lot of care, a lot of high intensive care. But there's not as many people dying now as there was previously.